So we're going to go to the last session of the meeting. And okay, not to offend Rami and Aaron, it's great to see their backs, but now I think we're going to go to probably what I think is the most interesting, potentially really fundamental part that we actually don't really do a good job. And it's talking about actually with our colleagues, because I think as hematologists, leukemia physicians, we can follow some of these guidelines and understand, the use of these drugs and so forth. But the reality, for those of us that are in academia, I think we're missing a couple of things. And I think one really interesting aspect of this meeting and the one that we had in Amsterdam was exactly how we put all this together. So I'm actually extremely happy to have the panel here, and I'm not going to go in the order that I have in the program. So the first issue actually is sitting next to John is Dr. Ulmer, who is actually a great friend in San Antonio, who is an outstanding, I hate this is not a pejorative term, but community oncologist, right? A general hematologist. So this is actually, academia, we talk like this, right? Community. No, actually, I don't know how you guys do it. It's so complicated. Like after 2 minutes of listening to Aaron, I kind of lost it a little bit. So really fundamental. Then we heard about the needs of our patients, right? Supportive care. MD Anderson has a huge palliative program, etc. But I think that we don't do a good job from the leukemia perspective, incorporating these colleagues in the care of our patients. That is actually really the total global approach to their care. And then, not finally, but almost finally, I have kind of a hypothesis that I don't know how to measure in the context of clinical trials. That is, for instance, if we go back to the impact of these newer drugs in anemia on survival. Is it possible that these drugs actually interfere, let's say a TGF-beta modulator, that has some other effects on cytokine modulation that may be actually affecting myocardium? And we learn a lot of this through coronal hematopoiesis and understanding that some of these myeloid cells are in the coronary artery bed causing like local inflammation. So is it possible that what we see in our clinic, improving the well-being of our patients, the survival of our patients, is not only based on some bone marrow improvement, but perhaps on better cardiac health or cardiac physiology? This is a question that I've been talking now for like maybe 6 months to a year, and I don't know how to incorporate it in the context of a clinical trial, but I think we should start measuring this, because these drugs don't really change the molecular characteristics of the disease, right? And even doing so, like if the VAF of these genes goes up or down, what does it mean? Yet we're missing all this aspect of the cardiac care and potentially other comorbidities that affect our patients. And unfortunately, for some reasons that are unclear to me, we are not going to have transfusion specialists, but this is actually a major deal in our practice, huge issue. I don't know if this is the same thing in Europe than in the United States, but at MD Anderson, for instance, this transfusion unit is a major deal that is actually quite complex and something that we need to understand better. So if we can integrate all of this, actually we'll get out being able to take care of our patients in a much better way. So for that, actually we have a great group of experts. So Dr. Ulmer from South Texas Center in San Antonio. I forgot the most important, the pathologist, sorry. So that's the other issue. Sorry, I'm going a little bit tangential here. Key. I couldn't do anything if I didn't have like the support of our pathologists. In the meeting this morning in the MDS group at MD Anderson from 8 to 9, 10 minutes discussing a case. Is this CHIP? Is this CCUS? Is this CMML? No. Is this oligomonocytic? So that's actually a really fundamental aspect of what we do. Indeed, I think people come to see our pathologists, not to see the leukemia doctors. So I'm very happy to have Dr. Sanam Logabi, who's one of our main hematopathologists at MD Anderson in this area. In terms of cardiology, we have Dr. Anju Noria from Dana-Farber Cancer Institute, that is a leading authority in this field. In terms of supportive care physician, we have Dr. Jenu from our group at MD Anderson, that I think is one of the top programs in the nation. And then unfortunately, we are not going to have our transfusion specialist, Dr. Adriana Knopfmacher, but we'll try to help her. Maybe some of you can also help me with her slides. And with that, we start. I don't know if, John, you want to add something? Or
No, I mean, I think this part of the meeting was the genesis of what we did in Amsterdam, was trying to understand, I think, the nature of anemia in these two diseases, and then what is the best way to manage anemia and the attendant risks associated with anemia in a multidisciplinary approach. So this is beautiful. This is what we're trying to accomplish today. So we'll kick it off.
So thank you again for Sohod and Dr. Guillermo and John for inviting me and the team. So as you see, this is a very interactive session compared to the previous ones. And first we'll start with a polling session. Consider your patient with myelofibrosis with anemia. And the patient is treated for anemia but is not transfusion independent. During one of the visits, your patient expresses concerns of lasting fatigue, likely associated with anemia. How do you address the fatigue for this patient and impact it has on the quality of life? Please provide few keywords that will summarize your approach. So you can answer that in using keywords.
So again, scan the QR code. And please help us, for those in the audience, with keywords. And I feel like we've punished our faculty by making them face the other side of the room. Naughty faculty. So 30 participants, only one answer.
Two now.
Two.
100%.
I think we are getting some good responses. I think the key issues include supportive care, palliative care, fatigue clinic, Luspa, transfusion support, optimizing cardiac meds, transfusion threshold expectations, goals, and myelodysplastic, ESAs. So all of these are very important. We discussed a lot about dealing with the disease, dealing with the transfusions, the inflammation. I think dealing with what it means for the patient, what is the patient's quality of life. I think that's what you all kind of point out here. So let's go to this patient voice.
What you have to do is pick a healthcare provider that you feel comfortable working through this journey. They're really going to become just like family to you. The surgeon at Northwell was in touch with Dr. Mascarenhas at Mount Sinai. And that because from a blood point of view, from an EMA point of view, I had to have a certain level of platelets going into surgery. Both doctors were communicating through this because I had to make sure, as I mentioned, that I was ready to go into surgery. So that was one thing. It's just communication and making sure that the surgeon and my hematologist were in sync. The bottom line, it's a team effort.
So we had a brief patient discussion. What the patient is trying to convey is that he has to go through the process. It is about cancer treatment, but also the treatment of the anemia, treatment of the inflammation. On top of that, he has to deal with various other things. Let's go to the patient case. So this is a 72-year-old male with a history of fatigue, and he's found to have severe anemia. Hemoglobin is 7.8 grams. WBC and platelet counts were within normal limits. Disease progression and treatment history shows that He is undergoing workup, including the bone biopsy, and ultimately it confirms that the patient has MDS with multilineage dysplasia. Bone marrow blast count is 1%, RS is 8%, and normal karyotype. The 40-gene NGS panel shows DNMT3A and ASXL1 mutations, and the EPO level is about 260. The key thing here is that in his treatment is that he's been requiring 1 unit of PRBC transfusions every 2 weeks. So the key thing that patient had to go through is various care factors. And as a supportive care team, we work as a team which consists not only about physician, but also counselors, the various nurse practitioners. What we kind of look into is screen these patients for not only the symptom burden, but also in terms of the function. But also the key thing we want to kind of look into is what other mobility or physical limitations they have. And on top of that, there is caregiver issues that can come across, and also mobility and also transport issues which come with this intensive treatments they have. So hand screening them for the symptom which commonly presents in these patients is fatigue, but it also implies very decrement in the quality of life. And the other important things we also look into is the other symptoms that commonly occur. One is with the worsening transfusion needs and the anemia. In addition to fatigue, there is significant shortness of breath and the bone pains that can occur. The key thing that is not many people realize is that there is so much of emotional distress, not only among the patient, but also the caregivers, but also the functional decline that can occur. And on top of that, there is a lot of financial burden for these patients. In addition to these concerns, the other things that can occur, and we all will discuss as a team, is about the transfusion burden that can be a problem in addition to the cardiac strains that can occur because of multiple transfusion. Now, the supportive care is very important in terms of not only taking care of the symptom burden, like we manage pain, but fatigue, but also shortness of breath, but also various important thing is developing trust with the patient and relationships so that we can take care of the patient throughout the trajectory. And the main thing we do is through counseling and psychosocial support. The other important thing is work with the interdisciplinary team to improve their function. And not only it improves their quality of life, but also improves their way to kind of feel meaning to their life. The other key factors that can play an important role by involving the supportive care team is helping the patients make decisions, and decisions which are goal concordant, and that's more important. And this is through continuous communication. We see at MD Anderson multiple patients at every day interval so that we can understand their goals and communicate with them regards to various aspects, including the needs for transfusion, including the needs about how long do they want this specific care to be done, where can be done, where can this care be done, not in the hospital-based setting, on the clinic-based setting, or at the community level. So we kind of help and facilitate with the primary team. So we are not trying to be the main team to take care of it, but as a complementary team to help to facilitate the decision making. And the most important thing we found in the recent research is that there are a good amount of evidence that not only the supportive care can improve the quality of life, symptom burden, but also improve various aspects, including the patient, the caregiver satisfaction, and also in terms of the survival. And this is by trying to communicate with the patient and the healthcare provider, including the oncology team. A lot of times, the oncology team feels like having less time to take care of this patient. And a lot of times, they are unable to screen various aspects because they have focused on the disease-specific aspects. And then there is the aspect of the stigma. Whenever we use the word palliative care at MD Anderson, there used to be no referrals to supportive care, palliative care at all. So in 2010, we basically changed our term palliative care team to supportive care team. And since then, we have a significant change, including the hematological malignancies. We have been having a significant increase in referral, and the referral pattern increased to about 1,300%. So it is a significant. We are about more than 100 clinicians who are able to take care of these patients. And the most other important thing is help to educate the patient. A lot of times they feel that the word palliative care is only at the end of life. We are here to improve the quality of life of the patient. And the other important thing is the patient is more focused about the disease progression rather than in terms of the quality of life, in terms of the function and the psychological aspects about it. And we kind of convey them. And the more important thing is help with the financial aspect about it with the help of the social team that we can work on. So these are various things we kind of work on to help as supportive care. But as we go through the discussion, we'll discuss more about the specific aspects. Let's talk about this think, pair, and share about it. Consider your patient with myelofibrosis with anemia, and he's been treated for anemia but not transfusion independent. During one of the visits, your patient expresses concern about lasting fatigue, likely associated with anemia. What do you address? How do you address the fatigue in this patient and the impact it has on quality of life? Please discuss with your table and then share the full group. Okay?
So they want to discuss for each table?
Yes, exactly. So I need to see some discussion, I guess.
So while they do that, can I ask you a question?
Please.
So should we consult you on the first day this patient comes to see me on day one?
So the importance is that it all depends on what are the trigger factors. We discussed a patient who has a very adverse mutation and significant transfusion need. The burden is high. In these kind of patients, it is always indicated to refer the patient right away so that we can screen and help the primary team, your team to help the patient. The most important thing is we have specific tools, not only looking at symptom burden, but also function, but also in terms of the psychological care that needs to be taken care of. And with the help of your team, we'll be able to kind of address these. The most important thing is some of the aspects of the care they do not want to discuss with you regards to what can happen in regards to the financial aspects about it, what can happen in regards to where the care can be provided, who will be available for the care. So those things are usually ignored, are not being taken care when you are told about it at the end. If you're taken care in the early part, most of these aspects are being addressed about it. So that's the reason early referral and early access has shown to improve the quality of the life patient rather than when they are referred late.
So let me ask a question and maybe ask Scott. And I don't want to say this is an N of 1 or 2, but this is reality. The patients that come to see us at MD Anderson, maybe they are a little bit stronger. They come from Austin or San Antonio, for instance, to Houston. Let's say maybe socioeconomic status a little bit higher, etc. So I remember, and maybe Rami can attest to this, is that every year with either MDS or the MDS Foundation, I don't know which one, we do these patient groups. And we've done that a number of times here. And then you see maybe, quote unquote, the real MDS patient. That is mid-80s with a lot of comorbidities, not really a transplant candidate, who really depends on his daughter to assist him. So maybe you see more of those patients than what we see in our place. How do we put this all together? How do you use this actually in the community?
Appreciate the talk, but there is no such referral source in the community. And so, as we all know, the bulk of these anemia and MDS patients are in the community. Only the fit financially and physically can make it to Houston and are willing to do that on a recurring basis. And so we do all of this in our office. And even though I live in the 8th largest city in the United States and very financially well-to-do part of town, there are no palliative care services. There is no one I can refer anyone to.
Need?
There's a clear need. There's a clear need. And it would be supported. But there's exactly zero. And I think that's probably true in most cities.
Let me ask our colleagues in Europe, Valeria, Is this an issue, or how do you?
No, the economical issue, of course, doesn't apply for Europe, as you know, not so much. So, but the rest, yes. And let's say the distances, the distances in Europe are also much smaller than in the US. So our patients do resent if they have to travel for half an hour. Also because they have to ask their caregivers, usually the family, the children. They don't want to ask their children to stop their job, their works, to bring them to the hospital. So I think that it is mainly the dependency that they hate. They really do dislike the fact that they have to come to the hospital to get the transfusions. As far as they can, they avoid it. But of course, if they have symptoms, dyspnea, and so on and so forth.
So in your center in Florence or in Milan, do you have access to supportive care physicians that can help you with this kind of approach, or
No.
No.
No, we do it ourselves. So we decide the frequency of transfusion, the level of hemoglobin. We talk with the blood center, the colleagues in the blood centers. We usually, we are in touch very frequently because some patients are more critical, and we decide usually all the kind of also supportive therapy that we can give. We do not have usually great help from the family doctors who should be in charge of this part. So unless, some are there interested and are, but usually it's our duty, which is on top of all the rest.
Yeah, I think there is more and more awareness going on. Before they were mainly focused on solid tumors, but there has been, the last decade has changed significantly in terms of hematological malignancies. And especially if you see at MD Anderson too, we would never had imagined hematological malignancies being referred when I initially joined, like in 2003 or something like that. Now we have about more than 40% of our referrals are from hematological malignancies. So it is a slow process, but it is catching up. And one is the availability, the second is the intent. So both are kind of catching up over the period of time. And not only in the United States, but also in various other places also, there is more and more focus about it. And in Europe, for instance, there is not a different thing. There are a lot of oncology teams that are actually providing supportive care and other things. So I see it more often, especially in UK and other places. But in Italy too, there are some specific areas that are more specific, like Bologna or in Sicily, other places that provide a little bit more of palliative care or supportive care compared to others.
The other thing I just want to point out, relevant to palliative care, supportive care, and the referrals, is that there is a clear cultural and language aspect that has to be considered. So practicing in New York, I get the privilege of seeing lots of different types of people from different parts of the world. And there's clear differences in the reception for a palliative care referral if you're from Southeast Asia or from different parts of South America than there may be if you're American or European descent. The acceptance of palliative care and the significance of it. I mean, I have patients where they have myelofibrosis, they're in the transfusion suite every week, but the family doesn't want you to tell the patient what the diagnosis is and the fact that the patient has a limited lifespan. So that's a challenge. How do you even refer a patient for palliative care if the family doesn't even want the patient to know? And they can get away with it because the patient doesn't speak English, so they can do the translating and they'll say everything is fine, you just need some red cells. And that goes on frequently.
Yeah, I think that is very often happens at MD Anderson too. A lot of times they just don't want the discussion about death or dying with the patient. Especially if you are from Middle Eastern cultures or Eastern cultures, that is very common. But they would be accepting supportive care. They would be asking for medications for pain, or if you have fatigue, or if you need the physical therapy, they are more open to that. As long as you don't cross that red line of talking about death and dying for them, because they feel that is very important for them to have hope for that given patient. So they don't do that. But As long as you tell them, we'll refer to supportive care for your management of fatigue, which is kind of very easy to tell, or for pain, that could be a easy conduit to get the patient the support system needed as they progress through the disease, or they get cured for their disease. So that could be one other thing. I think let's move on to the question. Anybody wants to give a small little thought process about how to manage fatigue? No? So let me take from my perspective, how do you manage fatigue in this kind of situation? The first thing is screening. You do screen for various aspects. Is the fatigue severe enough? Is it impacting the function? Or is it affecting the psychosocial function? Or is it affecting the cognitive function? Or is it affecting any of the various aspects in terms of the physicality, in terms of ability to do the daily activities? Those are the things that are meaningful for the patient. So the first thing I'll do is assess that multidimensionality of the fatigue, and then look for the reversible causes. We already discussed about disease-modifying therapy to treat fatigue, and also the anemia management, transfusions. All of these can be of very much important. In terms of the other aspects that are usually ignored is the symptoms. A lot of the symptoms that the patient has, like shortness of breath or pain or other symptoms, these can also cause severe fatigue. The most common thing that commonly ignored is anxiety, depression. These are very important in the causation of fatigue. So development of strategies to help with the patients, not only improving the function with the help of physical therapy or the various aspects to improve the exercise of the patient. There are also some Eastern strategies like Tai Chi, yoga, and other things you can try. But the most important thing is counseling. A lot of times counseling, breathing exercises, those are the things that patient can perform and kind of encourage them to do it. Medications-wise, very limited, but non-pharmacological strategies to help nutrition, to help the sleep, all of these can be of great importance in helping the patients to have less tiredness. The most other things that can also help is adjustment of the treatments. Some of the treatments that can be adjusted for the disease itself may help the fatigue in certain instances. Those are some of these important and simple strategies. Energy conservation is considered more at that very terminal phase, but most important thing is activity. Increase the exercise ability of the patient, fatigue will be a lot better. I think here I can stop and have our team from Dr. Anju Zora talk about cardiac iron overload now. Thank you.
Thank you for this opportunity. As the only non-hematology oncology person, I am privileged to be here. So I think I was asked to focus primarily on cardiac iron overload from transfusions and those effects. But given the conversation that happened earlier, I just wanted to talk offline without a slide about just the consequences of anemia and the shared biology between these diseases and heart disease. So I think one of the things that has been mentioned is that we all know that CHIP is a hallmark of these diseases, and it's also being increasingly associated with an increased incidence of acute coronary syndromes, heart failure, AFib, even aortic stenosis, right? And now there is a huge emphasis within cardiology, first, as to what do we do with these patients who now have CHIP. We have all these CHIP clinics where people who have these mutations are being sent to us for risk optimization, but honestly, it's unclear what we do for them beyond a statin, and making sure that their lipids are well controlled. There is an increased emphasis on looking at anti-inflammatory therapies in heart disease and their impact on cardiovascular outcomes. So we know that statins have anti-inflammatory effects and clearly benefit heart disease. There have been a lot of trials now looking at colchicine, which has also been shown to have a significant impact on coronary artery disease. The CANTOS trial looked at canakinumab and showed that it reduces recurrent MIs in people with a prior history of coronary artery disease. And then people are also looking at tocilizumab and specific inhibitors of the inflammasome, et cetera. So I think there is a lot of synergy between cardiology and the treatment of myeloproliferative disorders and MDS. And in fact, I really like the idea of doing, incorporating cardiovascular endpoints in your trials. So for instance, if you compare patients who are getting EPO, which is not disease modifying, and people who are getting these other anti-inflammatory therapies, and actually look at cardiovascular endpoints, or if you wanted, even something like coronary CT angiography, where you're looking for progression of coronary artery disease in one instance versus not in the other, you could really accelerate both diseases and help spread that basically knowledge. So with that diversion, I would say that chronic anemia, if untreated, can obviously increase your risk of MI, especially in people who have pre-existing coronary artery disease, which a lot of your patients have because they're older. The second thing that can happen is if you have untreated anemia, you can get high output cardiac failure, where the heart tries to adapt to the anemia by increasing stroke volume, increasing contractility, and all of this can lead to volume overload and heart failure on that basis. And then when you become transfusion dependent, especially if you have a very high transfusion burden, then you can develop cardiac iron overload. And this, in its early phases, manifests as diastolic dysfunction, where essentially you have iron deposition within the heart, which makes the heart stiff, so you get relaxation abnormalities in the heart. This tends to be a relatively asymptomatic phase, but in some people who also have splenomegaly, you can get pulmonary hypertension from that, and that can lead to right-sided heart failure. And often a question that I get is that someone's going for a transplant and they have pulmonary hypertension. Can they go for the transplant? And usually the answer would be yes, because if you get rid of their splenomegaly, the pulmonary hypertension will go away unless it's very, very significant. If the disease is left untreated and you don't recognize cardiac iron overload, then over time it can go on to develop systolic dysfunction or a dilated cardiomyopathy, and ultimately symptomatic heart failure. You also get iron deposition within the atria, so it's not uncommon for these patients to have atrial arrhythmias, AFib being very common. And if you have extensive disease, you can go on to develop ventricular arrhythmias, primarily because you're forming scar tissue within the heart where iron is replacing normal myocardium. And in extreme cases, you can also have an increased risk of sudden cardiac death. Usually, the diagnosis is sort of random in my experience, because there don't appear to be good guidelines for when you actually look for cardiac iron overload. Mostly people measure ferritin, and it's known that if your ferritin exceeds 2,500, your risk of having cardiac failure is higher. However, it can happen even at lower ferritin levels, as much as 1,000 or more. I tried to look up guidelines for when you should start cardiac monitoring, and I found very rough guidelines, something like if someone has a total transfusion burden of about 75 units of packed red blood cells, that's when you start looking. The Japanese have more strict guidelines where they say once you get 60 units, you should start looking. But what should you look with? Many people say you should do echocardiography every couple years to look for diastolic dysfunction. But as a cardiologist, I can tell you that that's very random, even within cardiology, and not a well-established diagnostic modality. If you see LV dilatation or low ventricular function, by then the horse has left the barn and your patient already has a poor prognosis. So really, the gold standard is cardiac MR to look for iron deposition within the heart. And the key parameter is T2 star. So basically, if your T2 star is over 20 milliseconds, you have a very low likelihood of having cardiac problems. If it's 10 to 20, you're at intermediate risk. And this is about 18% of all patients with MDS. And if you're less than 10, and particularly if you're less than 6, then you have a very, very poor prognosis. And this is about 4% of patients with MDS. Obviously, we see this more commonly in beta thalassemia and stuff, but less so in myeloproliferative disorders. In general, once you have iron deposition within the heart, you have to give iron chelators to try and leach out the deposited iron, and this can improve cardiac function, especially if you catch people early, especially when they're in that 10 to 20 range. Once they're below 10, and especially if they're below 6, then by then, again, the treatments don't work very well. In general, deferriprone has been shown to be more effective than other iron chelators because it's able to cross the cell membrane and get into the myocardial cells. Combination therapy is much more effective than single therapy, and this can be used especially in people who have higher degrees of iron overload. And if someone comes in frank systolic heart failure, cardiogenic shock, then really we give them intravenous continuous deferoxamine with concomitant deferriprone. And that has been shown to be the only way to try and treat these people, but by then it's pretty much palliative. Iron enters the cardiac myocytes via L-type calcium channel blockers, and there are some early studies in beta thalassemia to suggest that if you give a drug like Procardia or verapamil or diltiazem along with an iron chelator, you can actually reduce iron entry into the myocardium and have sort of a complementary or additive effect in addition to the iron chelators, but this is not common practice at this point. There's also animal studies suggesting that other drugs such as lipocalcin inhibitors, antioxidants, and hepcidin activators can also be helpful if used in combination with iron chelators. And obviously, if your patient has symptomatic heart failure, they should also get guideline-directed therapy for heart failure in addition to chelation therapy. So I would say that in conclusion, if you have ventricular dysfunction or symptomatic heart failure, you have a very poor prognosis independent of whether or not you use chelation therapy. Cardiac iron clears very slowly from the heart, so most of these patients require very prolonged therapy. You can use cardiac MR and T2 star as a way of looking at response to therapy, so T2 star should improve, and LVEF has been shown to improve primarily with deferriprone, but not with the other two iron chelators. And the key message is that early detection of cardiac iron overload and initiation of chelator therapy leads to improved cardiac outcomes. So we need to come up with better guidelines as to when to start monitoring these people and with what modalities. Thank you.
I don't know if they can hear you.
The mic, I think, is off.
Dr. Ulmer, I'm going to ask the question that Scott was asking. So should we order these MRIs at baseline? Because we don't routinely order them either. So what would be your suggestion?
So I don't think at baseline. I think the suggestion would be that some threshold of iron transfusion, right, beyond which, and one of the things as I said, in the literature I found some places recommend 60 units, some places recommend 75 units. I mean, iron overload happens much slower than liver overload. So I guess at what point would you start looking for liver overload? Do you guys have specified guidelines for that?
We do.
Go ahead. How do you do that in Italy?
We do start iron chelation after 20 red blood cell units, because at that stage we believe that iron overload is starting. So it is not based on ferritin. Ferritin is useful afterwards to monitor whether we have a decrease and on multiple measurements. And then, of course, this is hepatic in the beginning, and then can be myocardial. And we do have the procedure of doing sequential MRIs to check it. And yeah, that's the guidelines we wrote several years ago. Maybe we should, you want to add something?
Well, just the drugs that are used for chelation here won't get approved unless the ferritin is above 1,000.
Yeah, that doesn't mean anything. You can have...
Correct, but if they won't pay for it,
no,
they won't get it. The other thing is I write an order for, maybe my question was wrong, I write an order for a cardiac MRI today, remember 8th largest city in the US, and the result will come in 6 months. I mean, there's such a backlog for cardiac MRI. Is that true elsewhere?
6 months seems excessive, but again, we're obviously in a more
Right. So if I try and order one every 6
environment,
months
yeah.
and someone who's had more than 50 units of blood, it's
I think echo is not a bad modality. I mean, at least if you started to see some LV dysfunction, or if you have readers that can really look for diastolic dysfunction accurately, then you know that the disease has started, right? So even though it's, if you catch LV dilatation or LV dysfunction in an asymptomatic phase, that's still better than not at all. So I would say that if you can't get cardiac MR, then echo isn't a bad modality.
Let me ask a question that is not related to iron chelation, but I think is very important. So you mentioned the CANTOS study with canakinumab. And then you mentioned that some of your patients, or these patients, developed also some pulmonary hypertension. And I think one of the most intriguing presentations, I don't think the paper is out, but has been presented at TIHA, different meetings, is from this COMMANDS trial of Luspatercept. So on that study, there was actually pre-planned sequential kind of RNA-seq and some proteomic type of analysis that was done sequentially on the study. And what the interesting thing is that the TGF-beta modulator modulated IL-1, et cetera. So molecules that are interfered by canakinumab, et cetera. Pro-BNP, things like that. I don't know if the same applies in myelofibrosis. But one question that's starting to come is it possible that some of these effects that we see with this class of drugs are mediated by interfering with these pathways in myocardium more than in other tissues? And of course, there is a parallel TGF-beta inhibitor that is approved for pulmonary hypertension, I understand. So this kind of makes sense. So we never measure this on studies. I don't know how to do that, but what is your view on this? Because iron chelation is very important, maybe kind of an Italian discovery. And this has been very important, but now we're kind of missing the story of cytokine function on myocardium, how these drugs actually interfere with these pathways. Is it possible that these drugs are actually leading towards better outcomes in our patient population?
No, I would say yes, probably, right? Because again, independently, if you look at inhibition of inflammation in cardiac disease, it definitely is looking like it's a good thing. Not all drugs uniformly, but many different pathways are beneficial. So I think it is something where there is a crosstalk in terms of the biology and the pathogenesis of both cardiac disease and hematologic malignancies, and therefore incorporating cardiac endpoints that are more, telling in some way, right? Whether it be echo or whether it be, as I said, you could do coronary CT angiography because the disease appears to be more ischemia rather than heart failure, to look at, and nowadays you can do CT scans that basically give you coronary angiography and very detailed analysis, including like calcified and non-calcified plaque burden. I mean, we're doing this with ICI therapy, where we're looking at what happens to plaque burden in people who have chronic inflammation from ICI therapy. So this would sort of be the opposite of that. But again, these are expensive studies, so you'd have to kind of embed a sub-study where you look at that as an outcome.
So is there a cytokine profile that cardiologists use to follow this, or no?
No, there isn't like a set cytokine profile, but I think people look at the usual players.
Thank you. And Rami?
Sorry. I comment. We tend to think of iron overload in MDS just in patients that are transfusion dependent, but actually sometimes in subset of patients it may be part of the disease, whether the ferritin is just inflammatory marker, but I think you remember Guillermo Sanz presented 15 years ago in an abstract format, never published the data, but like 1/3 of the MDS patients, actually at time of diagnosis, before needing blood transfusions, they already had serum ferritin above 1,000. And I think in SF3B1 particularly, this is a very well-described phenomena that my simple explanation is the body senses the anemia, so increases iron absorption, basically. But it could be more complicated than that. But, so it's not really just the story in the correlation with the transfusions, because subset of patients could have it. And the SF3B1 particularly are ones that have it. So
some have hemochromatosis as well.
Yeah.
If you look at
Now what I'm learning is Dr. Gemino was talking about mobilizing the patients, but they need a cardiologist. So now that's like a triangulation axis that maybe we need to think more, right?
Great.
Thank you so much.
Who's next? Is it me? All right. Oh, hi, everyone. everybody. Thank you very much to Dr. Garcia-Manero, Dr. Mascarenhas, and the organizers for having me. It's a pleasure to be here. I do feel like I'm auditioning for The Voice, but instead of singing, I'm going to have to say something catchy enough for one of you to turn around and adopt me for your team. All right, and okay. No, well, we don't have the, so I'm the pathologist.
We're going to skip over this.
I'm just going to go through these. Okay, so the diagnosis. So I want to start by saying, instead of, I wish I could stand here and tell you all how great we are at making a diagnosis of MDS, but I think in reality, this is going to be more of a self-sabotaging talk where I tell you that we're really not good at making a diagnosis of MDS anymore. We used to be good at making a diagnosis because our diagnostic criteria were based on morphology and we didn't know a lot about the genetics. But unfortunately, our diagnostic criteria now lag behind our knowledge of, knowing the molecular drivers of MDS and knowing how MDS evolves. But, you still have to wait for the pathology report to say that there's dysplasia, to say that the patient has MDS. I think practically, this is, maybe not much of an issue. I would say that it's seldom that my diagnosis surprises Dr. Garcia-Manero or, my MPN diagnosis surprises Dr. Mascarenhas. They know by the time, before they get the pathology report. I'm sure Dr. Kamrakshi knows the patient has MDS or not. But the reality is that they have to, they need that pathology report to say MDS to get the patient on a clinical trial, to get the patient, approved for a therapy. And again, unfortunately, this remains an issue and a problem. We know a lot, of course, about the molecular drivers. And I would, pose to you a real-life example of a patient that we discussed this morning in our multidisciplinary clinic, in our MDS clinic, where the patient has transfusion-dependent anemia. It's treated for DLBCL. She has a TP53 mutation. She's trying to get enrolled in a trial. 4 expert pathologists from different institutions have reviewed this case. It's a 50-50 split. 2 of them say it's CCUS, 2 of them say it's MDS, right? So this is not trivial. I'm sorry, so here's the molecular landscape of MDS for you. This is not trivial, right? Because the therapy for CCUS, even high-risk CCUS, is, what is it? It's, I'll observe the patient until the P53 clone explodes. I may, if it's TET2 or whatever, I'll give them some high-dose vitamin C. But if I call it MDS on the diagnostic line and the patient has an SRSF2 and an IDH2 mutation or a TP53 mutation, they're going to get a transplant. So it's observation versus transplant. Not very good, right? Okay, so with that in mind, I will propose to you and to this panel that, and we've been trying to do this. The other thing, I want to tell you kind of off, I'll go back, off the taxonomy. As you can see here, the molecular landscape of MDS is very complicated. We know that there are 16 genetic, variants of MDS, and this is kind of even simplified. But if you look at CCUS patients, we recently reviewed hundreds of cases of CCUS. And remember, the diagnostic criteria for MDS is purely based on morphologic dysplasia in the 3 lineages, megakaryocytic, erythroid, and granulocytic, right? But when I looked at, in 3 days, I looked at hundreds of CCUS cases. You know what they all have in common? The ones that are molecularly high risk, they're hypercellular, their erythroid islands are disrupted, but guess what? None of these things are incorporated into our diagnostic criteria. So their bone marrows are not normal. So, the patient's transfusion dependent. They have 3 mutations. If I were the clinician and, the pathologist me said there's no MDS, I would say, I don't care what you say. This patient has MDS, right? So I think we need to get with the program and maybe, change the diagnostic criteria for MDS. On the other hand, I think for MPNs, let me go here. I do think that the issue is somewhat in contrast. I do think that our morphologic contribution to MPNs is probably better than our MDS, right? Because if you think about the molecular landscape of MPNs, particularly essential thrombocythemia and early prefibrotic PMF, the 2 patients can present with the exact same molecular drivers, right? They can have a JAK2 mutation, they can have, maybe an ASXL1 mutation, something. But I think the only way for you to know if the patient really has pre-fibrotic PMF versus essential thrombocythemia is the diagnostic bone marrow. So I would urge everybody in this room, if you have a patient and you think they have essential thrombocythemia, I don't care if it's a young woman, right? If for all intents and purposes, it looks like essential thrombocythemia, I think you should do a bone marrow to get a baseline bone marrow on that patient to make sure that they don't have pre-fibrotic PMF. And that's important. I think for P-Vera, it's a little bit questionable. If you look at the diagnostic algorithm, some say you may not need to do a bone marrow. I would argue that even for P-Vera, you do need to do a baseline bone marrow to be able to follow the patient. And also because JAK2 can be a chip clone. You know, you can have other, there are subtle differences, and I think it's good to get a bone marrow. And sorry, one of the squares here is missing. Yeah, okay, there you go. And again, the other hat we wear is, in addition to making the diagnosis, we also help our clinical colleagues prognosticate the patients. So for MDS, obviously by telling them the molecular profile, the karyotype, and helping them calculate the IPSS-M score. And I think for PV, PMF, and ET, there are several mutations that we know are prognostically important. Either they can predict shorter time to leukemia-free survival or resistance to some therapies. And again, I think it's important to molecularly profile the patient in the beginning, but also please get a bone marrow baseline so we can characterize the disease. And with that, I think I can finish.
Sanam, just a quick question. Outside the academic centers, what's your sense when you are reviewing slides from outside of it that people are starting to integrate NGS routinely? Is it getting better, or we are still lagging behind?
No, we were discussing this today. Even, I think, in academic centers, the integration is still really done by the oncologists, right? So it's very, outside of these boutique-type hempath practices, it's still actually rare to get a report that has everything in there where you can, use to treat the patient, and you kind of have to go and look for the different pieces of information in the EMR.
I think this is a very important question. So around, don't remember, 10 years or so, we published paper in Blood actually with Dr. Nagby when she was here about discrepancy between diagnoses. And if you read the paper, it says that the discrepancy in MDS was around 15%. Because the reviewer was excited but was very stringent in terms of the definition, but the true discrepancy rate actually was around 20 to 25%. So it made it into Blood, etc. And I'm curious, this is a huge effort actually, so I cannot get traction with my colleagues. Maybe we can do that together, because it will be very interesting to see if 10 years later, we still have this issue. Indeed, actually, Scott, one of the main reasons people come to MD Anderson is not to see me or Dr. Boss, it's actually to have a true diagnosis. What is this that I have? So that discrepancy rate is huge. And I think what you're talking about is really important, because at MD Anderson, I hope I say it correct and I'm not offending anybody, you get 3 or 4 layers of data.
Yeah.
So cytogenetics is your report, the morphology is another, the NGS. And sometimes they say waiting for morphology, waiting for cytogenetics. And we have to put all this together. We never treat, by the way, on a piece of paper even if they come from my dear friend, Dr. Mascarenhas, if I'm going to treat the patient, actually, I will repeat the bone marrow. I will not just treat on a report. By the way, solid tumor people don't do that. They treat on those reports. So this is actually a little bit of an issue, because if we show that the discrepancy rate is lower, this has economical issues for our patients and for us, and and it will make things a little bit easier. But I don't know actually if the discrepancy rate is any better or any worse than 10 years ago.
Actually, Amy looked at it, or through the NHLBI, we looked at it, and the discordance was pathologically higher, 20, 30%, still 25%.
But 40%.
Yeah, but we got to even how what is the percentage that it impacted patient management? And it was 7 to 10%. It impacted even the direct management or care of patient, not just disagreeing IB1 versus IB2, but something that impacts the treatment decision was 7% or 10% of the cases still. And this is, again, sites that enrolled in the HLBI, so a little bit more motivated and had some more pathology support probably.
The other thing I want to point out is, I think many of you have heard me say this before, is that the various layers of information that we have are important, because for myself, if I sign out a case, a lymphoma staging case, or something, if the case comes to me with a rule out MDS, I am going to be, hunting much harder for dysplasia as opposed to a lymphoma staging. But then if the lymphoma staging comes back with 3 mutations, I'm going to go back and, really hunt for dysplasia. And so I think there's an inherent bias in the way that the diagnosis is made too. So the additional pieces of information help us, but again, none of them have been really formally incorporated into, and I really think it's time that we change our diagnostic criteria.
Yeah. Thank you.
Yes, maybe a short comment from a clinical side, Sanam. What is your opinion on possibly integrating in a formal way very simple clinical parameters as a part of the definition of dysplasia? So I mean, a patient with severe anemia in which you have excluded all the possible differential diagnoses. For me, is a patient in which if there is a mutation for the P53, as you mentioned before, it's maybe a formal criterion associated with ineffective hematopoiesis and should be considered as a marker of bone marrow dysplasia.
Definitely. So, I think, I don't know who came up with this term, but I really like it, functional MDS, right? That is functional MDS. If you've truly excluded other causes of anemia, and the patient has a mutation, and the bone marrow looks weird, but it's not abnormal enough to call MDS, I mean, the patient has MDS, so yes, I fully agree. Yeah.
Thank you.
Yeah.
Best for last, I'll just say. So as a community oncologist, I was tasked with how can we bring in the supportive care from our standpoint. So I started thinking about the pressure points starting right at the referral. By the way, MDS is a syndrome, so you might want to think about the title. But anyway, if you want to narrow it down. I like options, so syndrome works for me.
Me too. I didn't come with that change. Maybe Comroque did.
Right. But right at the referral stage, I mean, to have a private practice where people are willing to see heme, people's panels are full, so that and it's anemia, you might say, well, that next available is 3 weeks, 4 weeks away. So right there's time. Apparently the diagnosis is very challenging, so we'll add another 4 weeks there before you get a path report with all your genetics. No one who trains does a bone marrow anymore, and none of us have the volume to have a nurse practitioner do all the bone marrow biopsies, so that's a referral to radiology. And then it has to get referred to hematopathology, so 2 weeks. So now we're looking at 2 weeks plus 4 weeks, 6, 8 weeks before you can actually get a diagnosis and start to make a plan. And let's say you're the person in the practice that does breast oncology and your patient has what looks like MDS. So you need to consult with your partners, you need to find some expertise, adds layers, and then treatment. And so we're limited by our treatments. Again, people who may be not doing this all the time may not know that momelotinib is better for anemia, or pacritinib is better for a platelet count less than 50. And so there's 2 of our 4 options. So not very many options. Look at lung. Lung has a 20 option tree where we have drugs for. And so all of that comes down, and then the economics, which is maybe not the most popular thing to say in an academic institution, but complex heme at best is neutral to a practice. If not watched carefully, you're underwater in complex heme. And so these are issues that take up your time, your staff's time, your front desk time, and your treatment room time if you're lucky enough to have a patient in the treatment room. And then the supportive care, great topic, but definitely challenge. These are very labor intensive, frequent visits. These patients come twice a week. Lots of transfusion time. Again, I keep coming back to this 8th largest city. I use it as an example because we have all the options available to us, but I have 2 state-of-the-art hospitals within 2 blocks of my office, but the transfusion center is only open Tuesday through Friday. And there's 1 nurse who staffs it, 4 spots, and most of those are Ulmer patients. And so this last weekend was Labor Day weekend. We still admit people to the hospital who are hitting their nadir for transfusions for a long weekend. I mean, that's not cost effective, it's not better, it's not great. So how to coordinate all this takes my staff a ton of time, it takes me a ton of time, and as I said, we have no palliative care services. So it really does come down to the oncology clinic. We can't expect the primary care doctors to know what to do. And so it's a lot. But when faced with challenges, you come with opportunities. And so it starts with communicating. Being here and able to talk to people about this is really helpful. The referring doctors, it's helpful. And even the practice, you know, they've got to be willing to support this kind of care. And then when you do that, if you can organize your doctors and your pharmacy and create a pathway, then it can work for the practice. The hospital does not know you care about these things unless they know. And so I'm volunteer for these hospital community committees, which I have no interest in being on, except that I can get my patients transfused. Same with the blood bank and the blood transfusion. You know, an MDS patient needs to be transfused below 9, 8.5 or 9, not the 6 or 7 that the ICU needs. But your transfusion committee will say no. And so you've got to be there and talk to them about that. It's really nice having tertiary centers who are willing to provide advice, be available on the phone when we call, be willing to see our patients who may not have trial options or a diagnostic option in our big city. And then treatments. So we need new treatments. These pathways help. We can direct doctors to these drugs. They're done as an outpatient. They're better earlier. They're better longer, better for everyone. We need referral destinations. We need trials, but we need trials that are meaningful with new drugs that make a difference like we see in the solid tumors. And then we can do it. We're the largest independent provider of phase 1 drug therapy in the world, but we have 0 trials in South Texas for malignant heme. Iron overload is a great example of the advancements we make. We used to see people with heart failure, and now with our oral chelators, early institution, early adoption, we don't, even without our MRIs. And then we create a multidisciplinary team too. It's not just in the academics. We've got the volume, we've got the business, we do it in our own place, but it's really important to do that. We invite the pathologists to our meetings, we invite the radiologists, and they come, and it's great. And so really working together at meetings like this can really advance the care of these patients. So, thank you.
I think we're running a little bit late, no, John?
Yeah.
Like 20 minutes. So maybe we'll start closing it. You have anything?
Yeah, so I mean, first of all, I want to thank the speakers today for joining us for this excellent session. This was probably the heart of the matter. Maybe if we do this next time, we'll start with the interdisciplinary discussion and then go on to the talks. I want to thank Guillermo for hosting us here in Houston for this meeting. I want to thank our faculty for joining us, all the attendees for attending and staying with us. For those of you that are interested, please scan the QR code or visit mli.link Soho pre-session to get your CME credit. We want to really thank MLI for putting this together and for our sponsors GSK, Geron, and BMS for their support. Please fill out the evaluation form to give us feedback. We're very interested in any critique, positive or negative, particularly positive, but negative too, and how we can maybe even change this for subsequent meetings. And thank you guys. Enjoy Soho. Thanks for coming.